Hello, everyone just joining us. Good to see you all. We will take our typical 2-minute start time and then we'll go ahead and dive into the content. Thank you for being here. I see some folks registered from all corners of the world, so hopefully this is an okay time for you all. It's good to see some familiar names and those who are new. If you're just joining, we'll get started in about 1 minute.
Okay, like that. Yeah. Just want to make sure I can see the questions.
Welcome, everyone. Thank you for joining. If you are just joining, we will get started in about 1 minute. Good to see you all here. Lovely. Okay, well, the beginning is usually just a bit of housekeeping. So as people are trickling in, we will make a start. Thank you all for joining us today, again, from all corners of the world. Hopefully this time zone is conducive to you. If not, thank you for being here anyway. We are talking about designing healthcare for clinician well-being and patient safety. And based on the number of registrations and the questions that we got from your registrations, it seems as though this topic will be one of interest to the group. As we are going through the content, I just want to say a big welcome to you all. My name is Olivia. I am the Associate Course Director for the Masters in Surgical Science and Practice, as well as the PGCert in Patient Safety and Quality Improvement at the University of Oxford. I work very closely with some of our panelists that you will meet today, and I'm very excited to welcome you here today. As I mentioned, this was a hot topic on registration, so you will have an opportunity to ask questions in the Q&A feature. So you can see Q&A in the toolbar at the top or bottom of your screen. And please do ask questions throughout. You may be aware that this Oxford Open Grand Rounds event is a little bit of a taster of some of the concepts in the Masters in Surgical Science and Practice and the PGCert in Patient Safety and Quality Improvement. So if you're interested in the concept today, I'll share some more information at the end about how you can learn more. I'm really excited to introduce our first speaker, Laura.
Hi everyone. So my name's Laura Vincent and I'm an ICU and anaesthetic consultant in Oxford University Hospitals. I'm the simulation and education lead in ICU and I've worked very closely with Helen over the years teaching patient safety and human factors in Oxstar. But actually I came at my simulation interest through an awareness and interest of the impact that education and simulation has on staff wellbeing. And I've ended up doing some research in burnout and wellbeing in ICU staff. So really interested to look at the scope of what we're going to discuss today. And thanks all for joining.
Thank you, Laura. And I'll pass it over to Lily. Welcome.
Hi, thank you so much for having me here. I'm Lily. My background is plastics, so I CCT'd in Pan Thames a couple of years ago. But I'm also a professional coach and I work with clinicians, predominantly surgeons, around aspects often of performance, but also remaining well and as fulfilled and happy as possible in what is such an incredible career, but can be such a demanding one. So I'm really delighted to join the panel today. Thank you.
Thank you, Lily. Great to have you. And last but not least, Helen, I will turn it over to you.
Thanks, Olivia. And yeah, really great to be here speaking about honestly such an important subject, and that became ever more apparent during the pandemic. So my background is in anaesthetics, and I'm the director of the Oxstar Centre here at the University of Oxford, and I run the HFTC module on the Surgical Science and Practice Masters. And over the years, I guess my interest in well-being, aside from being in the clinical workplace myself, has arisen largely out of my experience in safety incident investigation. It's become increasingly apparent to me the importance of workplace design and workplace culture, and we're going to be touching on quite a lot of those issues in this session. So I'm going to now share my screen. Livy, I wonder if you could, thank you, stop sharing yours, and hopefully this is going to work beautifully. Can you all see that slide, she said?
Yes, I can.
Obviously. Good, perfect. So what we were thinking about for the flow of this session is that we'll start by thinking what resilience actually means in healthcare contexts. We'll discuss the impact of design on well-being, and that's not just design of the physical workspace, but also the way it feels, the culture of the environments in which we work as healthcare professionals. And then we'll think obviously about the sorts of things that could make a difference over the course of the next 45 minutes or so. And so if I just pop this slide up to start with, I think it's important to define what we mean by resilience. It's a word that's bandied around quite a lot. And Lily and I were laughing about this on a recent podcast we did on the importance of education in surgery. And, it means a lot of different things to different people. We've chosen to use this definition about that ability to adapt or respond when things get a bit sticky. And really the purpose of this session is to think about how we ensure that this is my gang in the orthopedic theatre, right? How do we ensure that at the end of a day, we're all still smiling, right? And how even during a pandemic are we capable? Here's Laura, look, with the crazy backpack on, running around the hospital intubating patients. That was a heck of a time. And you think about it, we still found time to think about the sorts of things that we were proud of. And we had orthopedic surgeons learning new skills, helping us prone patients in intensive care and so on. How do we ensure that resilience remains in the healthcare workplace in such hugely challenging environments that we've already touched on? And I think one of the first questions that we thought we'd explore is what is it about the work environment, whether it's equipment, the physical space that you work in, the outpatient clinic, the operating theatre, whatever it is, and the teams in which we work, that makes a difference to our well-being and, of course, the important knock-on effect to patient care and safety. And I wonder, Laura, I know you've done a lot in this regard, and it's probably a little bit too obvious to say that in intensive care, the amount of pressure that you're under on a daily basis to manage the workload and the complexities and, the challenges of coping with family emotions and so forth. How do you support your teams in doing that without burning out?
Yeah, I think obviously everyone comes to work to do a good job and to do the best they can. But I think that we have a role in trying to make sure that everyone comes to work and also has a good day. And there's quite a lot of evidence that patient experience is a direct result of staff experience. So paying attention to the culture in the workplace that we're operating is going to be fundamental to staff having a good experience and having good well-being in their workplace. And that is going to have a direct impact on patient safety. It's going to impact outcomes, incident risks, and it's going to impact the patient care as a whole. And it goes. I think you've got a slide coming up to include Maslow's hierarchy. And this can be applied in all organizations and in all walks of life. But paying attention to all areas of this pyramid, right from the very basis of making sure everyone's fed and watered, has somewhere to rest, is safe in their workplace and is invested in, I think is important to pay heed to at all times, not just when you're having a teaching session or when you're having a debrief about something.
Absolutely. And I'm going to bring Lily in on that fairly extensively in a minute, because I know she's got huge experience in certainly from her coaching practice in thinking about these key issues. But I just wanted to explain to the audience the pictures here. So we wanted to convey the importance of the physical workspace in which we exist. And we don't just mean, what it feels like to be in an operating theatre. It's about the human device interfaces, all these different tools that we use, the electronic interfaces that we come across every day. During the pandemic, these hideous mask dispensers that never work properly, either pull out 15 or get one and you rip it in half and so on. And then no one's ever going to want to use these devices. But I think all of us can think of physical, environmental issues that cause us grief. And when we think about the core tenets of human factors, which are, when you're thinking about human-centered design, you should be thinking about what is it that's going to make work easy to do. But the twin aim has to always be that work the design of the space must feed into work about well-being. It must make people feel good to be in that environment, and that's not always the case in healthcare. And Lily, if I could, I'm going to bring you in now onto this issue of culture and support in the workplace for the highly pressured jobs that surgeons do, because I know you have very personal experience of that.
Yeah, thank you. And I love that Maslow's hierarchy is up, because I think we often forget that well-being is about a well human being, and we're people, as my mum would say, warm-blooded mammals. She grew up on a farm, and she's always amazed by how isolated we can feel as clinicians, despite being surrounded by other people. And I think when you look at this, at Maslow's hierarchy, he actually later in his career divided these into deficiency needs and growth needs. And the deficiency needs are exactly as Laura said, your, food, water, warmth, absence of disease, physical safety, psychological safety, belonging, esteem, and love. And those actually, when you think about it, in your average hospital job, aren't all met. And when you don't meet your deficiency needs, you're in a state of stress because you're trying to meet them. And only once you do, and throw in a bit of esteem and status, can you start to grow and learn and ultimately self-actualize, become the best version of you that you can, and then self-transcend, start to do things in honor of others. So I think there's quite a lot of work for a lot of us to do in creating work environments where those human beings behind the clinician feel safe enough to grow and to really contribute in the way that they want to. And I'd like to share an anecdote, which I think lots of you will probably relate to, which was the reason I got into coaching was because I experienced performance anxiety as a second year plastics reg. So I'd been a doctor for about 5 years, and I vividly remember the day this started. I was doing micro, just joining together two ends of an artery for breast reconstruction, kind of 2-3 millimeter vessels. And a consultant that I really respected walked behind me, looked at the screen and said, "Beautiful stitching." And I just suddenly became really self-conscious and started shaking. And I sort of looked around, everyone looked really embarrassed and kind of looked away. And the more I tried, the worse it got. And I got through the case, but I then became really worried that it would happen again. And of course it did in certain cases in front of certain people. And I asked some mentors of mine, some consultants I really respected, what to do. And there was just no advice available, apart from take beta blockers and get on with it, because that's what everyone else does, which is fine. And many people do. And I did for some time, but I couldn't believe that there wasn't more advice, particularly when I started noticing it around, I often noticed people with a tremor or with what looked like a cognitive manifestation of performance anxiety. Anyway, about a year later, I went to a conference and there was a doctor giving a talk, and he supports athletes and runs a performance center for athletes with this multidisciplinary team. And he was explaining all of the stuff they do, high-tech tracking and intervention, psychological support, physical support, nutritional support, all of it, sleep therapy, everything. And I sort of girded my loins and I approached him in the questions, and I shared this really shameful secret of mine that I just felt so mortified about, that I had this tremor and could I book in to see his team? And he just turned to me and really dismissively said, "Oh, you probably just need to do some mindfulness," and just turned away and spoke to the next person. And I felt so angry because this was such a massive issue for me and I'd been hiding it, and I felt so ashamed of it. I wondered if I was even cut from the right cloth to be a surgeon. And what was worse, it worked. And literally within 2 weeks, I was practicing mindfulness every day and I was able to completely manage my performance anxiety. Occasionally I'd get a tremor, I knew what to do, never took a beta blocker again. And it made me so mad that there is understanding around how to manage these things and the psychology behind it, this desperate need that we have to belong and to be good enough, that's based on our evolutionary past. And yes, it wasn't being shared with me and with the 87% of surgeons that we now know experience performance anxiety that negatively impacts their surgical performance in 2/3 of cases and their well-being in 96%. So I think it's really, really important to consider the education in our workplace, but also the openness with which people share their totally normal reactions to really unusual situations, and create a culture where we talk about it. Sorry, yeah.
No, Lily, that's great. It's such an important thing to get out there, isn't it? And I think the performance anxiety is different for us in anaesthesia. I don't know about you, but you go into an emergency situation, and as an anaesthetist, what tends to happen is you arrive and you say, I'm the anaesthetist, and there's this massive, oh, great, oh, massive relief. Someone's here that's going to just take over and sort it all out. And that can most definitely lead to performance anxiety in the way that you're describing. And in fact, that's where the kind of training that Laura's been talking about, this experiential training that can be offered in simulation, but isn't done enough in these high pressure specialties to help us cope with the management of acute stress in these situations is very obviously missing, and it's missing at a very basic level. I mean, if I just point to the surgical curriculum and ask you where within that curriculum is any of this? Where is there clear guidance on how simulation can support not just technical skills development, which of course we know is extremely important, but arguably more importantly, those sorts of skills that you're managing under pressure, performing when everybody's watching you. And I thought this over the years when when I've been in theatre and I'm looking at surgeons and the number of distractions that you guys get in the middle of a case, for example. I counted
managing coming in saying, when are you going to finish? When are you going to finish? Yeah.
And oh, I'm on call as well as trying to suture this nerve. And you're like, are you crazy? This, this is unacceptable. And these are the cultural issues that I think we're touching on here and that very nicely feed into what you've just described in Maslow's hierarchy of needs. I'm going to say something quite lighthearted now and say that when you look, arguably, you look at the bottom there, the need for air, food, water, health, that underpins everything, right? And I laugh about this a lot because at the start of the pandemic, I honestly have to say that there was a massive sense of relief in our hospital because we got an M&S at one end suddenly and a Pret at the other just before it all booted off. And you could suddenly get a decent cup of coffee in our hospital at pretty much any time of the day or night. And it's not trivial, is it? These sorts of things. There was a question that came in from the audience that said, what are the sorts of things the NHS could be doing that really aren't that difficult? And arguably, that is one of them, right? I think. But I think that the other aspects of system design that that we don't think about enough, and one of these issues came up in the question is what is the patient experience like? What does it feel like to come into an organization like ours and experience the physical environment, the technologies that they're exposed to, the team cultures, and the way that healthcare professionals speak to patients? How do we address those issues in the context of worker well-being and patient safety when everyone's under pressure? And I've watched this on ward rounds recently. Everyone's on a computer, writing on the computer, not looking at the patient. How do you fix that? What can we do about that?
I actually have a strategy on my ward round for that.
Excellent.
So with the number of people on the ward round increasing, so does the number of computers. So I try and limit it for 2. But also I have this thing that everyone laughs at me about with the ward round feng shui. So I don't allow them to place the computers in front of the patient, which is the natural thing to do at the end of an intensive care bed. And we sit and we stand at an angle so that you can see the patient, they can see you, and you can see the rest of the team. And it's just silly little things, but I think it makes a really big difference to a patient not seeing a wall of screens in front of them.
I completely agree. And I think that sometimes, Lily, I don't know what your thoughts are on, particularly around how we achieve better support for staff in the workplace, but there are some relatively simple things that we could be doing. And I know that coffee example was a fairly glib one, but I do think it's important. But around training, the things that you and I spoke about on our podcast a little while ago, I mean, I don't know whether you wanted to highlight any of the things that you think we could be doing more effectively and relatively cost effectively around, worker well-being.
Absolutely. So in preparation for this call, I went back through my, coaching clients, nearly 100 surgeons now, and other clinicians too. And there are 2 really clear themes that obviously everyone's different, but 2 really clear themes. One is the performance anxiety one, technically, also in relation to interviews and exams, public speaking, that sort of thing. But the other one is this real sense of overwhelm, of demands outweighing resource. And I think one of the things that's really simple and could be really effective speaks to exactly what you were just saying, Helen, about interruptions. So interruptions are incredibly disruptive. It takes, on average, well, there's a lady called Gloria Marks who's done a lot of research about this. She reckons it takes an average of 23.3 minutes to get back to anything you've started after an interruption, for instance. But at the very least, whatever happens, you get drawn out of potentially a flow state, a very effective state. You have to switch. Usually you have to switch context, and then you have to get back to reconnect with what you're doing, and there's an attention residue, and it's meant to take at least 25% longer to complete any given task if you're task switching. Now, there are obviously times where interruptions are welcome and important, like the anaesthetist arriving at a cardiac arrest. That's an interruption that everyone wants, but most of the time it is taking people away from their work, from what they're trying to do, from their focus area. So I think small things in the workplace, like creating permission around, but also space for uninterrupted work. That includes bleep free time, and specialties differ, but it's still the norm for the surgical reg on call to have the bleep in theatre, as you were alluding to. I think could massively reduce the concept of demand by reducing the length of time for each task. But also it could massively increase our ability to perform what we're trying to do effectively. I dare to say that the majority of people on your ward round, Laura, are unable to be effective because there are so many different interactions going on that the net sort of constructive output is very low. But I think the other time where it's really important for wellbeing to minimise interruption is when people aren't at work. And again, I'm not sure about other specialties, but it is normal in surgical teams to have WhatsApp groups for not necessarily patient details, but even just clinical chat around staffing and, stressful things, stressful messages people can read when they're in bed with their partner, when they're trying to bathe their baby, when they're just trying to have time out. And the importance of strategic rest is really built in. It's interesting to look at other professional groups. If you look at athletes or aviation, rest is enforced not only between shifts, but, at weekends or booking leave. And I think we're very guilty of not doing that. And I noticed there was a question around the quality of sleep,
Yes, exactly.
which has
I was just going to bring that in, Lily.
Yes, yeah.
What are your thoughts on that?
Well, there is nothing we can do in waking hours that's as important as the quality of our sleep for performance. It is critical not only in physical and mental repair, but also in coding memories, in emotional regulation, which is a big issue when you're talking about well-being and burnout and so on. And there are understood parameters that are required to optimize sleep. You have to sleep deeply enough in the first half of the night to get enough deep sleep. And you have to sleep for long enough to get enough REM sleep and have enough overall sleep opportunity. And in order to get that deep sleep at the beginning of the night, you need to be able to access a deeply parasympathetic state, which means not engaging with stressful content, which includes work messages, amongst other things. Regularity of sleep is also really important. And of course, shift work is a big problem for that. And we aren't recording the levels of fatigue at the moment.
I think it's such an important point, isn't it? There was a question, as you say, and a very specific one about how we're monitoring and managing fatigue. And the recent HSSIB report on fatigue is really insightful in this regard. The fact that we're just not doing it. We know it's a problem. Mm-hmm. And it's almost like that NHS mantra of feel free to cope is still pervasive across our organisations, wherever we work, whether it's in primary care, whether you're a nurse or a doctor or a physio or a pharmacist, it's the same thing. Feel free to manage in this awful system that is frankly sometimes setting you up to fail.
And no one's going to reward you for staying up all night if you then, make an error.
Yeah.
And it's this thing, there's sort of still this kind of message that you shouldn't be sleeping when you're on a night shift. And it's like, if someone's going to do an operation on me at 5:30 in the morning, I'd rather they'd had 2 hours sleep at an opportunity earlier in the night. And there is the opportunity to share that workload. Absolutely. But that comes down to environment and Maslow's hierarchy and what we're providing for staff as well. Because there is a complete a deficit of rest facilities within the hospital, and that's another thing, and it's always the bottom of the priority pile with new estates. And in fact, restrooms and ICU have all been taken up by offices for staff, and it's like, this is not acceptable. This is base level food, water, sleep, isn't it?
I want to bring it back a little bit, if I may, to the idea of how we support our people and mentorship and where that might sit. Because I had a recent call, I'm going to, make sure I anonymize this, but a call from a colleague who said that a new consultant colleague had arrived and was displaying all sorts of problems with behavior. And this was causing a great deal of stress to other members of the team in the workplace. And what did I think they could do about it? And I said, okay, well, let's just back off a little bit and think about, this sounds to me like a person in distress. What is it that you've got in place as a new consultant to support that person in coping with a transition from a registrar to, which we know is a huge step, and arguably, in craft specialties like ours, it's even more stressful because suddenly it is you where the buck stops and you're the one that has to make all the decisions. And I said, what have you got in place in terms of mentorship? Oh, we don't do that in our group. And I thought, gosh, I am going to confess that it was a surgical group. I'm not going to say where, but it was a surgical group. And it really interested me because it's absolutely routine in our team in anesthesia. A new consultant arrives, they are allocated a mentor. And that mentorship can go on as short or as long a time as is functional for that person. And in fact, I'm still mentoring two colleagues that started a number of years ago. They still come to me when there's issues. And to me, that should be an integral part of what it means to be a consultant in a team, wherever you work. And I'd value both of your thoughts on how that works.
Lily, do you want to go first?
Yeah. I mean, I absolutely believe, and it's interesting that we started with the definition of resilience. There's a consultant psychologist in Bristol, Dr. Olivia Donnelly, who I've done some work with, and she's also part of the support initiative. And she often says, resilience is between us, not only within us. And I think this is a real example of that, that those relationships that feel safe to connect with other human beings when you're making these massive and really uprooting transitions. I did a qualitative piece of work a few years ago where I interviewed 10 plastic surgeons from kind of right at the very, in fact, core trainee who wanted to be a plastic surgeon right up to very senior consultant. And one of the consultants who was relatively newly appointed at that grade said, once you become a consultant, the expectation is that you know everything. And I think there's a culture of that, if we're talking about workplace culture and change, switching from that sense of needing to be unassailable into one where there is always learning and always growth, and mentorship can exist in any direction. As a junior, you can mentor a senior consultant. As someone just a step ahead, you can mentor someone just behind you. And as a senior consultant, you can mentor someone who's just stepping up to the level that you're at. And it all has so much value for both parties.
Really nice points. And arguably, Lily, I don't know how you feel about this, because we've been doing some work with ICU nurses and nurses in our surgical emergency unit on stepping up to more senior roles and realizing that our colleagues in nursing don't do this terribly well either, and you make assumptions, don't you, about other professions that you're not embedded in yourself, that, oh, nurses, they must get this, they must do mentoring really well, but they don't have the bandwidth, frankly. They've got too many other jobs to be doing and there's no time. I think that's the constant refrain. So this program of bringing these nurses in and exploring with them using very simple tabletop simulations about what you do to prioritize at night when you're the one that's got to make decisions about patient care, about staff allocation, what happens when someone's gone off sick, how do you reallocate. These sorts of important safety-based decisions are not taught, and there's not that kind of strength of mentorship automatically in place for nurses or doctors, I don't think. And in ICU,
and it's
arguably,
often down to you to find your mentor,
yes,
isn't it? And if you're lucky to be in an environment where there's a plethora of people that you would turn to, then great. But some people are, as you say, much more isolated, which is why I think, setting it up and that being, I mean, you look at other huge successful organizations, big businesses, or they'll often have a kind of formalized onboarding process where, you know, you kind of have a supervised period, your supernumerary, you've got people checking in on you, you kind of orientated, etc. And there's just no time for that, seemingly, in the NHS, and you kind of often hit the ground running. We've actually tried to introduce this a bit for our fellows starting in ICU from overseas, because not only are they starting in a new department, but they might be starting for the first time in this trust, in the NHS, and actually in this country, and they could have come from a completely culturally different setup. So the overwhelm that they're feeling is just so extreme compared to somebody who's kind of come through our system. And we've tried to create an onboarding program a bit like that.
I think that's brilliant. And what I really love about that and about mentorship generally as well is, particularly for those people who may feel even more anxious than everyone else, but actually everyone, you know, as you've said, is likely to feel very anxious at these transition points. Through having a regular mentor appointment, for example, it's almost using that concept of worry windows, which is used a lot in psychology. And I spoke to a friend who's a professional rugby player. He has the same. He has a regular appointment with his coach and with his therapist in his team. And he said for him, it gives him so much relief because he knows he can park his worries somewhere. He doesn't have to constantly ruminate on them. He knows he has his, you know, Wednesday appointment with Helen to talk through those things, and almost he can put them in one place and know he's going to get through them and move on from them. And just having that structure in place, I think, can be really helpful in and of itself. Plus, of course, the benefits of saying it out loud, still belonging, and receiving advice back. So yeah, awesome that you've set that up.
Yeah, absolutely, and essential. I wonder if we might just bring it back in a little bit to the sort of system features that we talk quite a lot about in the programme, and the issues of the things that we touched on initially. We've naturally, and I think importantly, focused on what we do about culture in the workplace and support for individuals and teams. But the physical work environment and the equipment that we use is also massively important and very little focused on in healthcare. I've heard plenty of surgeons say to me that the female surgeons saying things like, "Oh, most of the equipment that's designed has been designed for men, so for bigger hands and for taller people and so forth." And then other issues of design, which I know we touched on in a light-hearted way in this slide, which actually would not be that difficult to fix, would not be that hard to fix. And this issue of co-design, which we never pay attention to. And if you think about the new infusion pumps that arrived in our hospital during the pandemic, without so much as oh, what do you think of these guys? They turn up and you just yeah, we love them. Not you know, the design flaws were so obvious to us that we're going to be using them immediately obvious, that it felt like such an own goal for the company not to have talked to the clinicians that were going to be using the equipment. Think about hospital beds. You know, the beds that we brought into the organisation that are really difficult to access the breaks. The side panels are impossible to keep up without banging them really hard. If you want to put an ICU stack on the end, we've had to make something to attach it to the new beds safely. So these sorts of design flaws, we tell a story in the programme about the original design of a water birth bath in maternity. It's the most hysterical thing. It was an enormous oval, high-sided pool, basically. No steps, no handrail, nothing. So women in labour were expected to get in and out of this thing. Midwives couldn't access the patients easily. And it took hold on a minute, why don't we talk to the midwives and the mothers about what this should look like, before they realised, oh, yeah, we should really have thought of that. And those aspects of designing things, and it might not be the design of a physical thing, it could be the design, for example, of a checklist. So, you know, checklists are everywhere in healthcare, but they are used very variably, I think is the way I would describe it. And it's only become apparent in the recent past, with all the research that's been done, the importance of design in checklists, and perhaps first and foremost is co-design. Get the people that are going to be using the checklist to go through safety critical steps in a procedure, to think about what those are and how they want to ask the questions,
and
which is exactly what you
do
did in
an
the pandemic.
iterative process
Yeah.
and go from
Evolve it.
the work as imagined to the work as done.
Exactly.
And actually like, well, this seems like a good idea.
Exactly.
We're now going to try it in practice, and we're going to reflect, and we're going to adapt,
and we're going
rather
to
than just
simulation
introduce. Exactly.
Yeah. And I think, again, just on the simulation theme, obviously when you say simulation to people in healthcare, they tend to think of plastic people, and we do use a lot of plastic people in simulation. They're very helpful. And if you ask the general public whether they think it's a good idea for doctors and nurses to practice on plastic people before they get to real people, not surprisingly, all of them say yes, that's a great idea. And yet we don't do it often enough in that sort of low dose, high frequency model that we've talked about. But whilst everyone gets why simulation is good for workforce development and training the workforce in healthcare, we don't think about it often enough as a method. So as a tool for understanding latent risks in healthcare. And the sort of thing I'm talking about is the work, for example, that you guys did in critical care. When you were moving from the old intensive care unit that we used all the way through the pandemic into the new fancy pants unit just outside here. And you thought very carefully about what it was going to mean to transfer all your critically unwell patients individually into that new space. And came up with all sorts of issues similar to the work we did with the new electronic anaesthetic record.
And it gives you a chance to try it out, make mistakes, learn from those mistakes, and make adjustments, rather than it being with a ventilated actual patient.
Exactly.
But in the same breath, if you have designed a space with patients through an iterative process, with an ergonomic perspective and a human factors approach, what you then can't do is then just repurpose a space. And I know we've talked before about the way that you'll have a broom cupboard that then, hang on, we need a space to do this procedures, procedures. We're just going to shove them in there. And actually then you're just exposing huge risk to staff and patients, both physical risk to staff and to patients, and safety risks, but also efficiency problems. And I think, if we do think systems design and environmental design is important, then we can't just go changing it willy-nilly and expect it all to be fine.
Absolutely.
Because it's just, paying lip service to it.
No, I completely agree. And it's why I've kind of moved us onto this slide saying, look, what can we do to achieve this sort of state of happiness at the end of it? Again, this is my Max Fax gang on a Tuesday. And I promise I did not make them smile. It was the end of a busy day, and we'd managed to squeak in an emergency as well as the elective work, and it felt good. So how do we achieve this on a day-to-day basis in healthcare? And some of the things we've touched on, back to Maslow's, food, drink, coffee at night, looking after your people, training them properly in that low dose, high frequency model, are some of the relatively simple steps. And these are questions that have been asked of us that we could be taking. I think it might be quite good because we've got a number of questions that came in before this session that I think it would be worth going to right now. And one right at the top that cropped up is, of course, AI is everywhere in healthcare at the moment. We're being scatterbombed with different devices that we're being asked to use as a way of reducing our cognitive burden and making our work easier. And in actual fact, it's failing fairly routinely when they're implemented, because funnily enough, we're not thinking about the ways that we implement them. And I think if you look at those documents that came out of the IHI and out of the Chartered Institute in the recent past on how we implement AI in healthcare successfully, they point to the importance of several things. So there are probably three areas in which they think, arguably AI is going to be most useful. So firstly, as an admin tool, so things that could capture your ward rounds, for example, and record them accurately. This kind of thing.
Hopefully not verbatim.
Letters and so forth in clinics where ambient voice technologies could be useful. Okay, so there's that. Then there's clinical decision support. It's a little bit more tricky, right? And I'm going to come on to why that is in a second. And then finally, they're talking about the importance of chatbots for patient information, right? That could be very helpful. But I think the three core areas where we're not getting it right yet is perhaps first and foremost, we're not thinking carefully enough about where in the healthcare system it is most appropriate to put these tools. Right, so that's the human factors system thinking aspect of it. We're then not thinking about what it takes to ensure that our healthcare professionals trust these devices, have confidence in what they're telling them. And then let's bring the engineers in and say, what we need to understand about the devices is the interpretability and the explainability of how they're working, why they've come to that answer, so that we then do trust and have confidence in them. And I don't know, I know that you guys in ICU recently had an experience with ambient voice technology. And I wonder whether you have thoughts on why that perhaps wasn't as successful as it might have been.
Yeah, I mean, again, I think partly it was because we were just sort of given it to try. And, you know, like with all of these devices, you know, everyone is going to operate in different ways. So my approach to a ward round, for example, is very different to a colleague's approach. And I think, again, trying out a new device, you want to be able to understand how the different people are working and therefore help them get the best out of that device. And in the end, my feeling was, oh, this is just going to slow me down. And I actually, you know, I was worried it was going to miss some of the things I was saying or misinterpret it. And actually, from an efficiency point of view, I therefore just abandoned it. Whereas I've got other colleagues who are a bit more bought into this kind of thing, who, you know, found it more readily implementable. I think there is a concern about governance as well, isn't there, with patient data?
I think people were very worried about, you know, what was being recorded and
where it was
some
going.
of the anecdotes I heard were when it came to having those sometimes very difficult conversations with families, it was switched off. Because they were worried about, you know, what exactly was going to be captured and where it was going and this sort of thing, which isn't entirely understandable. So I think there's a lot of work to be done on how we harness AI, just to that particular question. I'm gonna move us on to one that we discussed a little bit before this started, and maybe come to Lily on this and think about this issue of what we do when there might be a disagreement between colleagues and how you avoid that when you're discussing a patient's treatment in the presence of the patient and or their family. So we talked a little bit, didn't we, about transparency, honesty, and so forth. Lily, you had some interesting thoughts on the way to approach this.
Yeah, well, I think my first thought was, why remove it from them? There are lots of situations where there are multiple ways to approach the same problem and genuine clinical equipoise. And having been a patient myself, and recently with one of my parents, I think I really appreciated being given, and I appreciate that I'm saying this from the point of view of a medic, and perhaps it was easier for me to weigh things up. But the basic principle of autonomy states that patients should certainly be heavily involved in the decision making, and every, you know, as far as possible, be given the tools to understand the decision that they're making. And my view is that as clinicians, we should facilitate that process, and that clinical debate is actually incredibly helpful to hear. You know, I think it helps in understanding the disease, it helps in feeling enrolled in the process, and it gives an opportunity to state health beliefs that can be very deeply held, and I think are very important to reflect in the decision making.
Completely. And I think that's, you know, perhaps even more obvious when it comes to safety incidents. You know, being honest, something's not gone according to plan. Here's what's happened. We're sorry it's happened, and we're going to, you know, take a step back and try and learn from the events as they've evolved. And I've certainly, over the course of the past decade or so, when I've been investigating safety incidents, I've had some what you might call courageous conversations, Lily, with patients and their families, because you've quite simply got to be very open, and it can mean quite heightened emotions are expressed, and managing those is, you know, it's a big part of our jobs, no matter what role we're in.
I think just slightly related to that, Lily, there is some quite good evidence as well from surgeons that the better the communication is from surgeons to patients, the lower the chance of complaints then from patients when complications do happen. And for me, we were talking a bit about this beforehand. From my own experience, I've always found patients to be very grateful for very explicit information. And I know everyone varies in how much information they give. For me, I'm talking particularly in reference to anesthesia before an operation. And I often find people are very thankful for the explanations that are given. And I think if people feel informed, it helps them feel empowered. And then if things don't go quite to plan, or there's a complication and you've communicated so well and in kind of engaged that trust and that shared, accountability, you're more likely to have a situation that can be managed well afterwards, or in the event of something less good happening.
That's such a nice point. And I think it goes very much to what we discuss quite a lot, both in the online program we run in this hospital and in the module, the importance of compassion, right? Surely it's barn door obvious. Why do we need evidence that compassion is important in healthcare? And yet it's there in spades. And if anyone's interested, there's a great book called Compassionomics. You could just Google it, you'll find it, which explores very beautifully all of the evidence that points to, and exactly what Laura's saying. There's very clear evidence of reduced litigation, for example, from the United States, where surgeons are more open and honest about what to expect about what has happened, and about situations where complications have occurred. And I think the value of compassion is not only obvious from the standpoint of team performance. We all know what it feels like to go into a work environment where you feel that people have got your back, where you know you're going to have a good day when you see a certain group of people in the work environment. And the flip side of that is how it feels when it's not like that, when you're not seeing the kind of people that are on the screen there. You don't know them. It's the middle of the night. It's an ad hoc situation. It's an emergency, and you don't know anyone. And that's where all of the important non-technical skills around good communication with your colleagues, around introducing yourself, around wearing a hat with your name on, is hugely important. And being kind to each other, being polite, being civil, makes a massive difference. And the evidence is not just around team performance, as we're saying. It's very much around patient outcome as well. So yeah, I think hopefully that's answered that question on patient engagement, and I think it always goes back to the issue of honesty. There was another one that interested me, because rather fortunately this morning, one of the DM students in the Oxstar research group was speaking on the call, and she was talking about her research in Kenya, on how anesthesia providers in Kenya, which is a very different context you can understand from working in this country, cope with the very obvious pressures they have, where workforce capacity and so forth is concerned. And the question that we were asked is, what lessons on clinician wellbeing can high-income systems learn from low-resource settings? And so I put that question to Hilary this morning, and she was saying, it's exactly this kind of thing I'm asking. But perhaps not surprisingly, that very human aspect of connectivity, of knowing who you can go to for help, is at the heart of it. And those lessons are the same whether you're in a high income or a low to middle income context. And that actually, of course, the nuances are going to be there in the way that anesthesia, for example, is practiced, because in Kenya, certainly, a very broad range of individuals. So you can have doctors, nurses, and I'm going to forget the title they give them now. It's like our ACCPs, our advanced clinical care practitioners, exactly, physician associates and so forth, can practice anesthesia. And so they come from different clinical cultures already, and that presents an interesting difference in the way they cope under pressure and who they turn to for help. But I think where the differences are concerned, at the heart of it, it's more of a similarity. It's more about the importance of human contact, of feeling free to speak up, free to put your hand up and say, I don't know, can you help me? That's so important. I don't know whether either of you have any more thoughts on that, whether indeed, Lily, you've got any experience in low to middle income contexts.
I think, well, just to really echo what you've said, and I think also, and I have limited experience, but enrolling families as well, and really connecting with the support structures of patients themselves, which often plays a much more practical role in very under-resourced settings or lower resource settings. But I think it's a really important lesson for us here too.
Yeah, most definitely. Okay, well, I'm gonna move us on to the question around debriefing after sudden traumatic events. These sort of moments where, you know, everyone has had a stressful experience in a team, and perhaps the patient has survived, perhaps they haven't. What do we do afterwards? How do we establish a culture of debriefing after these incidents? And it seems quite obvious, perhaps, to turn to Laura. I think both of us have had experience of the so-called hot debrief. But this is something you feel quite strongly about, and the psychological safety around setting those conversations up.
Yeah, and the timing of them, which I think is really important. I do think that as we have become more experienced and more comfortable about analysing safety as incidents and how we learn from them in a productive and compassionate way, there is something of a risk around debriefing that they become a learning discussion and something to do with kind of analysing this incident from a kind of, you know, safety point of view. But it's really important to recognise that the importance of, firstly, a sort of temperature test, making sure everyone's okay, either immediately afterwards or at the end of a shift, which is not a full psychological debrief, but a kind of, you know, supportive sense check. But then actually that when you do organise a formal debrief, which shouldn't be too long after the incident, but should allow time for people to have had the chance to go home, decompress, for some of their feelings to emerge and for them to process some things and have questions, that should be structured as a psychological debrief from which some learning may come, but it should not be the focus of it. And people shouldn't feel that they can't be present and can't open up in the way that they might because it's a safety incident analysis. And those things need to be separated, and so I think that's really important.
And I don't know in your coaching practice, Lily, whether you've come across issues that have arisen as a result, perhaps, of poorly managed post-traumatic stress in surgeons.
Yeah, absolutely. I think, and again, teams differ, departments differ, but broadly speaking, there is not a robust and reproduced system for dealing with, for instance, an adverse event, a complication or an error for surgeons. And Kevin Turner, who I mentioned earlier, published a paper with his team around the experience of surgeons after an adverse event. And they're fascinating findings. 36% of them had the clinical symptomatology of PTS. I think from memory, 48% were experiencing anxiety, 43% sleep disturbance, 11% using excessive alcohol. And 43% of them had not spoken to a soul, not a colleague, not a partner, and less than 3% to a professional. And I think this, again, I'm on my soapbox, I know, but talks about having a culture where it's fine to be affected and it's fine for things not to go as planned. And they do. You know, in the same survey, 80% of surgeons had experienced an adverse event of some kind in the last year. They happen.
Really interests me, Lily, because we just recently did a piece of work because a trainee in anaesthesia came to me and said, I've had this awful experience, you know, after a safety incident. I don't think we've got adequate structures in place to support people after these sorts of events. Can we have a look? So we did a survey and got a lot of responses, very interesting responses from anaesthetists, and thought, well, great, let's replicate this in the surgical cohort. And very interestingly, no one replied. So this went out to resident surgeons only, not to consultant surgeons. So maybe there would have been a difference. But it really, it kind of worried me a bit, you know. And this was a repeated request. We sent it out a few times, and we did get some responses, but I think maybe 5, and 3 of those 5 said, "Oh no, I've never been involved in a safety incident," and I found that quite hard to believe. So it's clearly happening, right? We all know it is, because as an anaesthetist, if I'm in a safety incident, I'm usually in it with a surgeon. So it's going to be, it's out there and it's happening. And I worry that culture of being able to talk about it is perhaps not as obvious as it should be in surgery.
Helen, we have a hand up. So Anu, I see your hand up. I'm going to allow you to come off mute if you want to share your question with us. You're on mute right now. We can't hear you, but
sometimes Zoom takes a little minute, doesn't it,
if you could speak, go ahead and chip in. Otherwise, please.
I mean, if it's difficult to speak, you just pop the question in the chat. I think we've got a few minutes to.
Sorry,
I
accident.
can hear you. Yeah, hi Anu.
Sorry, I didn't mean to have my hand up. I was having.
Oh, no problem at all.
I was listening though.
No problem at all. Yeah, I mean, I think this issue of what we do after safety incidents is one that gives me still great cause for concern, and it surprises me to this day, as someone that's been an educational supervisor for a long time, that I'll come across people that don't know what steps you take. Educational supervisors that don't understand if a resident doctor has been involved in a safety incident, this is how they should be supported, because there are actually structures in place, but I just don't think people are aware of them as they should be. And I think that certainly for consultants, again, I'm just not sure that people are aware, and there's still too much of a feeling of being a bit worried. It's definitely better than it was, don't get me wrong. Since I started in this, since we started teaching human factors maybe over 15 years ago now, the feeling was very different than it is now, and that's a good thing. That's a really good thing. And I think the advent of things like PSERF and much more systems approaches to thinking about safety incidents, the evolution of HSSIB has also been tremendously helpful. But the messaging around learning from safety incidents rather than blaming when a safety incident has happened still needs a little bit of work, I think. Good. So I am a little bit mindful of time. I think we've got 4 minutes left till the end of the session. Livia, I don't know if you wanted to come in and say a little bit more about the master's program to finish off with.
Indeed. Just first, a big thank you to Lily, Helen, and Laura. I think we have time for one more question, and it looks like we have a hand up. So Walter, I'm going to allow you to come off mute, and then I will go ahead and close this out. Go ahead, Walter.
Thank you so much, Olivia. Can you hear me?
Yes, we can.
I just had a question about these type of psychological stressors, and has there been much research done on how it affects clinical performance? And if so, in what way does it affect it?
So the answer is yes, and badly, if I'm going to put it very simply. And I think that the kind of stresses that we've been talking about all the way through this program, and the thing, the anecdote, as she calls it, that Lily spoke about in her own experience of performance anxiety, very obviously the things that we're talking about, the concern we all have, and if you just look at the HSSIB report on fatigue and the impact that has on performance, both physical and mental performance. And indeed, in the Compassionomics book that I mentioned, there's quite a lot of literature around, the way people feel and how it impacts their performance. It's very clear that we're not doing enough, A, to understand it, or B, to support people who are struggling in the workplace, whether it's through mental ill health or physical ill health. Lily, I don't know if you wanted to say anything else about the impact that things like coaching might possibly have on this sort of problem.
Yeah, I mean, I think that coaching is one of many avenues to develop self-awareness and self-management strategies, to learn, to carve out time for and learn how to self-reflect. And I personally have found it really useful, obviously, well, not obviously, but that's, I appreciate my bias. I think therapy is also a really helpful modality amongst many others. And I also don't think that you need to go and see a coach. I think there are lots of ways that you can reflect on your own, and lots of AI tools now around coaching, which can be more affordable. But the advantage of seeing a physical coach is that it holds you socially accountable and financially accountable. And it can be very difficult to prioritize self-development work in a very urgent job otherwise.
Yeah, absolutely. Walter, I hope that's answered your question.
Yes, thank you so much. It seems it very much reflects the research that we've done on practitioner fatigue here in the States.
Yeah. Absolutely. I think you'd find the HSSIB report, it's free to access, quite compelling.
Thank you so much. I really appreciate it.
Not at all.
Wonderful. Well, with that, we are right at time. A huge thank you to Lily, Laura, and Helen for an excellent topic that we don't talk enough about in our day-to-day work. So thank you for being here. Thank you all for joining from the audience and submitting some quite thought-provoking questions in the registration and here live with us. As I mentioned, if you are interested in learning more, this Oxford Open Grand Round session is a taster of some of the concepts that are featured in the Masters and PGCert courses. If you would like to see some of the previous Oxford Open Grand Rounds, you can head over to our website. We did one in September about what's next for AI in surgery. So you'll see a library of different topics that feature concepts from the course. And of course, if you are interested in staying in touch with us, please scan the QR code on the screen here. You can also find us at the link at the bottom of the screen. And if you have any questions, please email us at ssp@nds.ox.ac.uk. Thanks everybody for being here, and we will close out the session.